Let's talk about the shoulder joint. It's this incredible piece of engineering, a true biological marvel. But here's the thing, it's also a massive paradox. It gives us this amazing freedom of movement, but it's also by far the most unstable joint in our entire body. So over the next few minutes, we are going to break that paradox down piece by piece and give you a super clear, logical framework that is perfect for absolutely acing your next anatomy exam.
So here's our game plan. We're going to start with the shoulder's central design challenge, what I call the mobility paradox. Then we'll build the joint from the ground up, looking at its static framework, and then we'll add in its dynamic muscle support. We'll see how it all works together to create this symphony of movement, find out what happens when things go wrong, and then we'll wrap it all up with a powerful exam-ready summary. All right, let's kick things off with the single most important concept you need to get for your essay, this fundamental conflict that sits right at the very heart of the shoulder's design. This is the question, right? Your ability to throw a baseball, to reach up for something on the top shelf, even just scratch your back. It all comes from this one joint. But all of that incredible freedom, it comes at a really steep price, and that price is a constant nagging risk of instability. Here's the textbook definition you're going to want to lead with in any exam answer. It's a synovial joint, which just means it has a fluid-filled capsule for nice, smooth movement. And it's a ball and socket, sure, but the key word here, the one to underline, is multi-axial. That's the one. It means it can move in every single direction, up, down, forward, back, and full rotation. This is the source of both its amazing talent and, well, all of its problems. So, how on earth does the body even begin to deal with this problem of instability? Well, let's build the joint from the ground up. Starting with the static, non-moving parts, this is the passive framework that provides its first line of defense.
And here it is. This is the core of the problem. It's a total mismatch. You've got this huge spherical ball, that's the head of the humerus, and it's sitting on this tiny, really shallow socket called the glenoid. Honestly, the best analogy for your exam is a golf ball balanced on a golf tee. It's just not a secure fit, and this, right here, is the anatomical root of the joint's instability.
So what's the body's first trick to try and fix this? It's the glenoid labrum. Think of it like a little fibrocartilage bumper or a suction cup that runs around the rim of that shallow socket. It makes it just a little bit deeper and helps to cradle that humeral head and keep it in place. Now, surrounding the whole joint, we've got the capsule. But here's the thing. Unlike the hip joint, which has this really tight, strong capsule, the shoulder's is thin and loose, it has to be, to allow for all that movement. The absolutely critical point to remember, especially for clinical questions, is that its weakest spot is at the bottom, the inferior part. There's just not much there to support it. Tuck that fact away, it's a huge giveaway later on. And finally, we've got the ligaments. Think of these guys as passive guide ropes. The glenohumeral ligaments help out at the front. The coracohumeral supports the top, and the coracoacromial arch acts like a roof to stop the humerus from popping straight up. They give it some strength for sure, but as we're about to see, these passive ropes are nowhere near enough on their own. Right, because those static structures just can't do the job alone. The body has this brilliant, active solution. And this brings us to the real heroes of shoulder stability, the muscles.
Okay, if you're taking notes for your exam, get your highlighter out. This is the money mnemonic right here, SITS. This stands for the four rotator cuff muscles, and they are the primary dynamic stabilizers of the shoulder. If you only remember one thing, remember SITS. And this table just lays out their genius double duty perfectly. You see, each ischiatus muscle has a day job, a primary movement, like the supraspinatus, which kicks off the first 15 degrees of lifting your arm out to the side. But their most important job, their shared job, is to actively pull the head of the humerus and clamp it down, holding it snug in that shallow socket during every single movement. They are the true source of the shoulder's stability. Okay, so we've got our static framework and we've got our dynamic stabilizers. Now let's see how this entire orchestra plays together to create that incredible symphony of movement. So this table shows the big movers, but check out abduction, that's lifting your arm out to the side. It is the perfect example of the teamwork we're talking about. The supraspinatus, one of our SITS muscles, it starts things off. It does the first 15 degrees, and then, like a relay runner, it passes the baton to the big, powerful deltoid muscle to finish the job. Every single action is this carefully coordinated effort. Now, with all these muscles and tendons gliding around, you've got to prevent friction, right? And that is the job of the bursae. These are just little fluid-filled sacs that act like tiny cushions between all the moving parts.
They're essential for smooth movement, but they can get inflamed, which leads to a really common and painful condition called bursitis.
We've built the whole system, but this is where you show real mastery in an exam, applying that knowledge. So what happens when this elegant but fragile trade-off between mobility and stability inevitably goes wrong?
Well, the most common failure is dislocation. And guess where it happens? Anteriorly and inferiorly, exactly where we identified that weak spot in the joint capsule earlier. A huge complication you have to mention is potential damage to the axillary nerve, which wraps right around the humerus there. That can lead to weakness in the deltoid and numbness over that classic regimental badge area on the side of the arm. Next up, rotator cuff tears. And the most frequent victim is the supraspinatus tendon. Why? Because it has to pass through such a tight little space to do its job. When it tears, the patient will have a lot of pain. And that classic sign, they'll have real difficulties starting abduction. They just can't do that first 0 to 15 degrees on their own.
And finally, we have frozen shoulder. Now, this isn't a tear or a dislocation. In this condition, the capsule itself is the problem. It gets inflamed, it gets thick, it gets scarred down in a process called fibrosis. And this literally locks up the joint, causing severe pain and restricting movement in pretty much all directions.
Okay, let's pull all of this together. If you find yourself running out of time in an exam, these are the high-yield, absolutely essential points you need to hit to structure a fantastic answer.
Think of this slide as your essay blueprint. Start by defining the joint and its parts. Emphasize that shallow socket and the role of the labrum in trying to fix it. State clearly that stability really depends on the dynamic rotator cuff muscles. Make that core connection. Most mobile means least stable. And finally, discuss the key clinical conditions as direct consequences of its anatomy. You hit these points and you're set for a top grade.
So there you have it, the complete story of the shoulder joint. We've seen its built-in conflict, its clever anatomical solutions, and what happens when it fails. The final question to leave you with is this. Now that we really understand this fundamental paradox, how can we use that knowledge to better protect this incredible but very vulnerable joint? Whether it's through physiotherapy or even surgical design, the answer always lies in respecting its anatomy.